reproductive pathology. All right, so for reproductive pathology here, we're going to be talking about the specific sex hormone issues. Okay, and so this is going to be problems with the formation of essentially our internal tubules, right? So it's going to be a problem with the formations of our Müllerian or Wolffian tubules. All right, and we'll talk about each one of them specifically. So starting off with aromatase deficiency. Aromatase deficiency is the inability to synthesize endogenous estrogens, right? Because aromatase is needed to change androgens into estrogens, right? Now, so if the fetus has this problem, it's going to lead to virilization of the mother and daughter. What's virilization mean? Virilization just means they start to look like a male, okay? They start to grow facial hair. They start to get secondary male characteristics, okay? Now, the reason behind that is because since the fetus is unable to convert androgens into estrogens, you get a buildup of androgens. The buildup of androgens can cross into the maternal circulation and lead to virilization of both the female infant and the mother. All right, so you can see like acne, hirsutism, which is just facial hair growth, and then fetal androgens can cross the placenta, leading to this issue. All right, so if you ever see virilization of the mother and the daughter, it's aromatase deficiency. All right, now going on to the more difficult ones. All right, a lot of my buddies and I had kind of difficulties understanding this, so let's take this step by step. Next is androgen insensitivity syndrome. All right, so this means that we have a defect in the androgen receptor. All right, so let's take a moment and think about this for a second. If I have an XY child, a 46XY child, they are genetically male, all right? And since they have the Y chromosome, that means that they could potentially have the SRY gene on the chromosome, on the Y chromosome, right? Not potentially, but most of the time, if you have the Y chromosome, unless there's like some crazy thing that happens, you're gonna have the SRY gene. The SRY gene is gonna form our testes, right? And what did we say our testes did? Our testes have two cell types, Sertoli cells, all right, which produce Müllerian inhibitory factor, among other things, but they're going to produce Müllerian inhibitory factor, which leads to the regression of our Müllerian tubes, right, our female tubes, and then our Leydig cells, which lead to the production of our Wolffian tubes, our Wolffian ducts, right, our male ducts. Now, how does the Leydig cell lead to the production of the Wolffian ducts? Well, the Leydig cells produce testosterone in order for that to occur. So within these patients that have androgen insensitivity syndrome, the testosterone is being produced. Everything that I have said has worked so far. The Y chromosome has the SRY gene. The SRY gene has created testes, and the testes have the Sertoli cells, which secreted the Müllerian inhibitory factor, so that caused regression of our essentially Müllerian tubules, right? But then our Leydig cells are producing testosterone, but wait, the testosterone is unable to bind to its receptor. There's an androgen insensitivity problem. The androgen receptor is not working. There's a defect in it. So I can't bind my testosterone. So it's as if there's no testosterone being made at all, right? Because if testosterone can't do its actions on its receptors, then it can't have its actions later on seen. So what happens is that you get regression of the uterus and the fallopian tubes because you have the presence of the anti-Müllerian hormone from the testes, from the Sertoli cells. But you also have the absence of any male tubes or any male internal organs because the patients can't sense that they have their own testosterone. But the levels in the body tell you have increased levels of testosterone, right? But there's nothing else going on. They have oligospermia, and they have sparse facial hair, and they have like barely any pubic hair as well. And then when they go to check the external organs, reproductive organs, the patient's going to have a blind vagina. They have no internal genital ducts, all right? And they'll have a blind vagina because that is the essentially default that will fall down, okay? Because we have no androgens working. Even though there's increased androgen levels in the bloodstream, none of them are able to act on the receptor and work and affect transcription or translation. All right? So make that make sense in your head. Androgen insensitivity syndrome, what happens? You have an XY patient. They come in. That means they have the SRY gene. That means the testes can be formed. Everything's good. Sertoli cells produce Müllerian inhibitory factor. So you have regression of the fallopian tube and the uterus. Those don't form. But then you also have the Leydig cells, which produce our testosterone. The testosterone's fine, but then it goes to bind and go and affect transcription translation to make our internal genitalia, but nothing works. All right? So the patient's going to present with a blind vagina with no internal genitalia, neither male nor female. Very important key concept. You have to understand androgen insensitivity syndrome. All right? So you can see increased levels of testosterone because it has nowhere to go. Next is 5-alpha reductase deficiency. So what does 5-alpha reductase do? Let's talk about this pathology. 5-alpha reductase is going to be our main enzyme that converts testosterone into DHT. Well, what are the differences between testosterone and DHT? DHT's functions, we said, as the way to form our penis, our scrotum, and our prostate. Okay, this is the external genitalia of the males, except for the prostate, right? So without 5-alpha reductase, we have 5-alpha reductase deficiency, we can't have a good production of the penis, the scrotum, and the prostate, all right? But what happens is that regardless of 5-alpha reductase deficiency, at puberty, testosterone becomes the main growth factor for growing our external genitalia, and DHT starts to regress in everyone. So in these patients, you will actually have at birth ambiguous genitalia, but at puberty, you will see that the patient will grow a penis and scrotum as well as a prostate because testosterone takes over because of testosterone surge secondary to puberty. All right, so atypical genitalia until puberty is usually what they say. All right, now, testosterone and estrogen levels here are normal. All right, because 5-alpha reductase deficiency, well, you will see testosterone and estrogen levels that are normal, LH levels is normal. Okay, the only thing that you're going to see as a decrease is DHT. And these are going to be, once again, 46XY patients. Now, last one's Kallmann syndrome. Kallmann syndrome is the easiest out of all these. The reason behind Kallmann syndrome being easy is because you look for two things. If you see lack of smell, loss of smell, anosmia, with a decrease in GnRH, that is Kallmann syndrome. All right, that's it. That's your answer. Kallmann syndrome presents with two main things that you have to know. If you ever see a patient, or if you ever see the vignette talking to you about loss of smell, anosmia, and then they're talking about reproductive issues, oh my God, the answer is going to be Kallmann syndrome. Decreased GnRH and decrease in smell, Kallmann syndrome. That's your answer. Okay? That's all for these pathologies. This is a very hard topic, and they ask questions on them. So make sure you understand it.